All right, we're starting with chapter 8.
Has everybody taken the test?
What?
Has everybody taken the test?
Yes.
So if we have a question, we can ask it.
I just don't want it to start a waterfall effect because we have so much content to get through. Can you send me an email?
I'll email it to you.
Okay, cool. Thank you. I think I'm going to switch over to my hotspot because I think people are already having issues. So
Can anyone hear me at all?
yeah, I can.
Maybe it's my internet connection. I'm going to disconnect and rejoin.
I can hear you.
Justice needs to be let in, or is she not in here? I'm in her.
I think her internet.
Can you guys hear me?
Yeah,
Yes.
now we can.
Okay. All right. I finally switched over to my hotspot. Okay. So, overall, we had an average of 77% after analysis. Somebody got a 94. That was awesome. That was very good. So endocrine is just notoriously one of the most difficult subjects. So I'm glad we got through it and it's over. You will see some of the same questions pop up on your final. So, and we will talk about that.
Jess, you're still breaking up and lagging really bad. I don't know if it's my internet or yours.
No,
I was gonna
it's
say the
breaking
same
up really
thing.
bad.
Yeah, it's
I didn't
happening
hear
for all of us.
anything you said.
I think she froze now.
She froze. There you are.
Can you start over, Miss Simmons? We didn't hear anything. Froze.
Girl, I didn't even start. I switched back the Wi-Fi. Do I sound better?
Yeah.
Okay. You guys are always funny in the chat. I said, whoever got a 94, can you share those notes? I want to study with whoever got a 94.
For real.
Thanks for making me laugh. I needed it. All right. So we're going to start off with chapter 8. We're going to talk about anti-infective agents. Did I share my screen? Sure didn't. I promise I'm going to get it together. Okay. Everybody see my screen?
Yeah.
Okay, so this just goes into like the history of anti-infectives. So in the 1920s, Paul Ehrlich worked on developing a synthetic chemical effective only against infection-causing cells, and we discovered penicillin from oranges. I'm sure most of you know that, but oranges got moldy, and all of a sudden, a scientist guy found penicillin. So, in 1935, they found sulfonamides and introduced those. Since those early developments, we have a ton of antibiotics. Many organisms that were designed to treat are adapting to repel the effects. This is what we call antibiotic-resistant microorganisms. No anti-infective agent possesses total selective toxicity. So there is no June, try to leave and then come back. I don't know. Everybody else can hear me, right? Okay.
Yes.
So there is no antibiotic or antiviral or anti-anything that is the end-all be-all of all bacteria or all viruses, okay? So when it comes to antibiotics, we always want to be cautious. You don't want to overuse any antibiotics. And the more you overuse antibiotics is exactly how you get antibiotic resistant bacteria, which things get scary when you have a patient dying from an infection that cannot be treated because of resistance. So kids, you always want to use caution. You don't want to expose children to antibiotics really early on in life. Just because not only does it add to the resistance, but it also can, you can develop an allergy or, a sensitivity to anything at any time. And exposing children to things really, really young can harm them. And we're talking about huge renal development, cardiac, digestion. I mean, everything in that first year, that infancy is just exploding in developmental growth and physical growth. So there is controversy over the use of antibiotics for ear infections, which, I mean, obviously every single one of us has had an ear infection. They hurt. Could you imagine not treating an ear infection for your baby? I'm not doing it. Anyways, adults often demand anti-infectives for a quick cure. And obviously, we want to be cautious. Most of us have had children or know someone that has children. You basically can't take anything when you're pregnant. It's very, very difficult to treat anything while you're pregnant. And then older adults, we talked about the Beers criteria and how dosing needs to be adjusted for our geriatric population because of their decreased renal filtration and just renal function in general. So, and older adults often do not present with the same signs and symptoms, just like when we're talking about UTIs, when, your granny her first sign is confusion, when for us the first sign is, dysuria or urinary frequency.
Why does that happen?
I'm
Why does
honestly
it
not sure,
change
to be
over age?
honest. I'm honest. So there is just normal things that change with age, which is why the renal function, a decrease in normal function is normal as we age. And I'm talking about aging into like the elderly population. But why they get confused over other symptoms, I'm not sure. So the therapeutic actions of anti-infectives, every classification is kind of different. So they could interfere with the biosynthesis of the pathogen cell wall. So the cell wall could be weakened, or it could destruct the cell wall in some way. It could prevent the cells of the invading organism from using substances essential to their growth and development, interfere with steps involved in protein synthesis, interfere with DNA synthesis, and alter the permeability of the cell membrane to allow essential cellular components to leak out. So that is true, like cellular destruction. They vary in effectiveness against invading organisms. So you have narrow spectrum antibiotics, which are effective only for a few microorganisms. They're very specific with their metabolic pathway, the enzyme, or the way that they destruct the bacteria. Then you have broad spectrum antibiotics. They interfere with biochemical reactions, and they're broad spectrum, which means they affect, oh my God, come on, Jess. I keep wanting to say negative and positive, but that's just not the right thing to say. Thank you. Gram positive and gram negative. Thank you very much. My brain is with one of your classmates and I am unwell. Anyways, they could be bactericidal or fungicidal, which cause cell death, bacteriostatic or fungostatic, which prevent or slow cell replication. I do want you to know the difference between what bactericidal and bacteriostatic means. So, trigger warning, I do kind of connect like bactericidal to suicidal. So like it's just makes me think of death. So bacteriostatic is just slowing and preventing. So the human immune response, the goal of our immune system and the anti-infective therapy is the reduction of the population of the invading organism. So at this point, the immune reaction can eliminate it. So really, antibiotics and our immune system are working hand in hand to work together. Drugs that would eliminate all traces of any invading pathogen might be toxic to the host. So that's when you're talking about like chemo agents, things that are so heavy hitting. Even some antibiotics can be like this, so heavy hitting that not only are they killing the bacteria or whatever they're doing, they're also harming the human. So the immune response involves complex interactions among chemical mediators, leukocytes, lymphocytes, antibodies, and locally released enzymes and chemicals. So anti-infective drugs are not effective on all pathogens that cause illness. So we know that antibiotics do not treat viruses, right? I want you to really get that stuck in your brain. Antibiotics do not treat viral infections. Okay? It's impossible. They have absolutely no effect on a viral organism. So our standard precautions are always going to be very, very important for patient education, nursing education, education across the board. Hand washing, removing invasive catheters as soon as possible, which is like triple lumen catheters, like central lines or Foley catheters. And you want to keep immunizations up to date and following transmission-based precautions. So your CDC PPE precautions. What is the number one way to decrease the transportation of infection?
Washing your
Washing your
hands.
hands. Washing your hands.
Washing your hands. So resistance of bacteria, this is the ability over time to adapt to an anti-infective drug and produce cells that are no longer affected by a particular drug. You may think that bacteria are like these little teeny tiny organisms and they're not very smart. They are brilliant. Bacteria and viruses are absolutely brilliant. The way that they adapt and change is actually very scary. And the more resistant they become, the scarier and harder it is to treat these organisms, especially if it's like a mega outbreak. We'll talk about those too. There was a hospital a couple of years ago that they had an outbreak in their ICU of Klebsiella, and they couldn't figure out where it was coming from. And I believe it ended up being tracked all the way down to the handle, like the support rails that are lining the hallways, and that people were touching them and then going into the critical care rooms without washing their hands, and then touching their patient, and all of their patients were dying of Klebsiella, and they couldn't find an antibiotic to treat it because it was so resistant. So natural resistance, anti-infectives act on specific enzyme systems or biological processes. Microorganisms that do not use that system or process are not affected. And then acquired, microorganisms that were once sensitive to the effects of a drug develop acquired resistance. That's most of the resistance that you're going to see, is that they are acquired. So acquiring resistance, they produce an enzyme that deactivates the antimicrobial drug. So they're just like, you're funny. You can't work on me anymore. And they change the cellular permeability to prevent the drug from entering the cell. They can alter binding sites on the membranes or the ribosomes, which then no longer accept the drug. And they can produce a chemical that acts as an antagonist to the drug. So they can use all of these ways of resistance. They can use 1 or 2 or 3, it doesn't really matter. But the more resistance they have, the more dangerous the microorganism is. Which is a major consideration when treating infection in a person who is immune compromised. What do we think? I hear no
A.
one. A. A is correct. So a significant consideration is that the person may lack the immune response to deal with even a few invading organisms. While proper nutrition is important, it's not as critical as a concern as the effects of the person's immunocompromised state in their ability to fight infection. Exercise is also supportive of a healthy immune system, but may not be recommended for the immune compromised patient. While it may be difficult to treat such patients because anti-infective drugs may be unable to completely eliminate the pathogen without causing severe toxicity, this this does not preclude the use of drugs. So remember, I said your antibiotics, your anti-infectives are working hand in hand with your immune system. So if the antibiotics don't have the support of your immune system, they can't do everything on their own. They do need help eradicating the infection. So preventing resistance is, very important. We want to limit the use of antimicrobial agents to this treatment of specific pathogens sensitive to that, sensitive to that drug. Make sure the doses are high enough and the duration of drug therapy is long enough to treat the infection. Advise patients to take the entire course of the drug and be cautious about the indiscriminate use of anti-infectives. If you ever want to get me really riled up, just talk to me about how you don't finish your round of antibiotics and I'll get really upset. So, it is extremely important that we do what's called a culture and sensitivity. A culture and sensitivity is a test ran by the lab that shows what the organism is and which antibiotic they are susceptible to. So it will have the antibiotic on one side, it will have, bless you, a list of antibiotics on the other side, and it will literally from all the way down, susceptible, not susceptible, susceptible, not susceptible. So that's something that we have to be very cognizant of, especially in the hospital. Your infectious disease doctors will often run culture and sensitivities. So it's important to pay attention to that. You also don't want to take, antibiotic for only 3 days when you really needed it for 7 days, because after that 3 days wasn't enough, that infection is going to come back raging. Okay. So treatment of systemic infections, identification of the infecting pathogen is done by culture. We just talked about this. Sensitivity testing is to determine which drugs are capable of controlling that particular microorganism. So this is literally a culture and sensitivity. So combination therapy, some drugs are synergistic. In infections caused by more than one organism, each pathogen may react to a different anti-infective. So you could have 2 bacteria that are causing an issue, causing some type of infection, and you could have one antibiotic that's working for that one, and you could have another antibiotic that's working for the other one. Sometimes the combined effect of the different drugs delay the emergence of resistant strains. So sometimes it kind of slows down those resistant strains. Prophylaxis. Prophylaxis is something that we don't want to misuse. It is only used in specific situations. People that are traveling to an area where malaria is endemic. So a lot of time when you travel out of the country, sometimes you will require vaccinations or prophylactic antibiotics before you go to that other country. It just depends on the specific country. Patients who are undergoing GI or genitourinary surgery, patients with known cardiac valve disease, valve replacements, and other conditions requiring invasive procedures. I know somebody, I think it's Amber, works in a dental office or something. And I don't know if you've ever heard of this, but there are people that have had a valve replacement or any type of endocarditis. They have to be treated prophylactically with antibiotics before they go to the dentist, because bacteria from your mouth can easily just go right into your bloodstream during a dental procedure, and that blood goes straight to your heart. And the thing about new valves is that they get sticky, and bacteria is very attracted to it. So when that happens, we call that vegetation on the valves, and that can be very dangerous, and it's very hard to treat. Adverse reactions to anti-infective therapy. Kidney damage is going to be one of your biggest ones. GI toxicity. Really, we're talking about C. diff, megacolon, and we'll get into those too. Neurotoxicity, hypersensitivity reactions like anaphylaxis, and then super infections like I was telling you about the Klebsiella at that hospital. That's what you call a super bug. So you are caring for a patient who has just been diagnosed with Pseudomonas infection. You know that in deciding what anti-infective medication to order for this patient, the physician will take what into account?
C.
C.
The answer is C. It's the drug that causes the fewest complications. The provider will consider the drug that causes the fewest complications. An antifungal agent should not be used on infection that is not caused by a fungus. Interfering with biosynthesis is only one of the ways in which an anti-infective may work, and the half-life would not be relevant to this selection. There are some antibiotics like I had cellulitis on my arm, which was just so random, like 2 weeks ago. I had to take Keflex 4 times a day. Like, what? 4 times a day? And it's because the half-life is so short with that specific antibiotic. I was like, that's a really long time. All right, chapter 9. Okay, so this is looking at antibiotics. I'm going to preface this by saying that just like a lot of our other drugs, antibiotics are going to have zebras, and also they are mostly all nephrotoxic or hepatotoxic, and a number one contraindication to all of them is allergies, just like all the other drugs. Okay? When it comes to antibiotics, it's very important to pay attention to your zebras. Okay? So, antibiotics, they are chemicals that inhibit specific bacteria. They're made in 3 ways: by living microorganisms, by synthetic manufacture, and in some cases through genetic engineering. So at one point, before genetic engineering was even a thing, we had run out of resources to make new antibiotics. They can't, well, now they can be genetically engineered, but before that, you can't just go out into the world and just be like, well, this one looks good, I'm going to use that one, because we already found them all. I mean, I'm sure there's more that we haven't found, but they are sparse, which is why resistance is something that we need to prevent. So again, this is bacteriostatic, inhibits the growth of bacteria. Bactericidal, kill the bacteria directly. Like I said, I need you to know the difference. Signs of infection. I also need you to know this, not only for your exam, but as a nurse and a mother and a friend and a colleague and a father and all of the things. I need you to know that the signs of infection include a fever, lethargy, elevated white blood cell count, and classic signs of inflammation, which is redness, swelling, heat, and pain. Also, sometimes it can even include a very low white blood cell count. So the goal of antibiotic therapy is to decrease the population of the invading bacteria to a point at which the human inflammation immune system can effectively deal with the pathogen. Because what did I say? They work together. They work hand in hand. We've already discussed culture and sensitivity. A culture is the identification of the causative organism. So this is the bacteria. We are identifying the bacteria. The sensitivity is determining which antibiotic will best kill or control the organism. So we have gram positive, which means the cell wall retains a stain or resists decolorization with alcohol. We've all done some type of microbiology, whether it was in high school or whatever. I would be very surprised if none of you have ever seen a stained slide, or at least seen a picture of it and looked under a microscope. If you haven't, please let me know. I will send you a picture. But a gram stain is when the cell structures on that slide, they turn like a purplish red. And then gram negative is when the cell wall loses a stain or is decolorized. So it's literally whether or not that cell wall can retain that color or not. Okay. And it just shows a significant difference in how the cell wall is made. So that's how they differentiate. Another way of differentiation is aerobic versus anaerobic. Aerobic bacteria need oxygen for survival. Anaerobic bacteria do not need oxygen for survival. So if you have ever seen anyone get a blood culture or have heard about someone getting a blood culture, you have two bottles. They're usually glass bottles. They can be plastic, but they're usually glass. And there always is a set of two. There's never one. It's always two, because one is anaerobic, one is aerobic. Okay. And the most appropriate way to do a blood culture is with a brand new venipuncture. It cannot be from an old IV site. It has to be brand new. It has to be cleaned very well with chlorhexidine. The tops of the blood culture bottles have to be cleaned with alcohol, and then they have to be completely filled. These bottles are like this big, and they have to be completely filled all the way to the line. They can't be short of blood or they won't work. And then you always have to get a second set. That second set has to be from a different site. Normally, they say that it should at least be from a second venipuncture, but they prefer it to be from the opposite arm, the opposite extremity. So if you get one in the right arm, you should get the other one in the left arm. And they should be at least 10 minutes apart. Most people don't do that because they don't want to sit there for 10 minutes and then re-stick their patient. But it can never come from the same venipuncture. Okay. Bacteria and resistance to antibiotics, they adapt to their environment. The longer an antibiotic has been in use, the greater the chance that the bacteria will develop into a resistant strain. The use of antibiotics may result in development of a super infection or overgrowth of resistant pathogens. There's a reason we don't see penicillin often. Okay. There's a reason why we have first generation, second generation, and third generation cephalosporins, who is a cousin of penicillin. That's important. You're going to need to know that. Cephalosporins are related to penicillins. So if you have a penicillin allergy, you may also be sensitive to cephalosporins. You should write that down. So the first group of antibiotics we're going to talk about is aminoglycosides. This is a group of antibiotics used to treat serious infections caused by primarily aerobic gram-negative bacilli. So if you think back to anatomy and physiology or microbiology, you remember there's different types of bacteria. There's streptococci, there's bacilli, there's rods, and it's all these little bacteria that are shaped differently, okay? So aminoglycosides are working on oxygen. The bacteria that it's working on needs oxygen. They're gram negative, which means it's not holding on to that stain when it's looked at under a microscope. So these all end in mycin. Your most common ones are going to be gentamicin, neomycin, streptomycin, and tobramycin. Aminoglycosides are bactericidal, which means they kill the organism. So in their mechanism of action, they inhibit the protein synthesis in susceptible strains of aerobic gram-negative bacteria. They irreversibly bind to a unit of the bacteria ribosomes, leading to misreading of the genetic code and cell death. What do cells need to be able to divide? They need DNA. They need to be able to split their DNA and go through mitosis to be able to replicate and grow in numbers. So this is messing with their genetic code, which is causing them not only to die, but also the inability to replicate. Okay. So it's hitting them in two different ways. Pharmacokinetics, they are poorly absorbed from the GI tract, but rapidly absorbed after IM injection, and they reach peak level within 1 hour. So with these drugs, most of them are not going to be an oral medication. Okay. Tobramycin is used often in eardrops or eye ointment. Gentamicin is used often IVIM. So they are widely distributed throughout the body. They cross the placenta and enter human milk. They are excreted unchanged in the urine. Most of the antibiotics that we talk about are not really going to be safe for pregnant or lactating humans. Okay.
Could you repeat those last two antibiotics? I got what they were used to treat, but the transcript isn't picking them up right.
Yeah. Is the transcript not working at all, or is it just misquoting?
No,
me?
it's working. It says what it thinks you're saying.
Oh, okay. So the last two are streptomycin and tobramycin. So
I got it that
contraindications and
time.
cautions. What?
The transcript spelled them right that time.
Oh, nice. Contraindications and cautions, of course, known allergy to any aminoglycosides, renal disease, pre-existing hearing loss, myasthenia gravis, or Parkinsonism, which is specifically signs and symptoms of Parkinson's. It can mimic those signs and symptoms. Use caution during pregnancy. Use lower doses with patients who have renal impairment, and risk for nephrotoxicity and zebra ototoxicity. Ototoxicity. Hearing loss. If something is ototoxic, that means it is toxic to your ears, your capability of hearing. Okay. Gentamicin specifically, but all aminoglycosides are ototoxic. So adverse effects that are serious and limit usefulness include CNS effects, renal toxicity, GI effects, cardiac effects, hypersensitivity reactions. When we talk about GI effects, that's really always going to be nausea, vomiting, diarrhea. Okay. Any overuse or even just regular use of antibiotics, specifically oral antibiotics, but also others. So here's the thing. In nursing, you never use words like always or never. Okay. Those are what we call absolute statements, because there will always be a variable. There's always going to be that one that is different, right? It's never going to be all people or no people, okay? When you take antibiotics, especially if you are immune compromised or in the hospital, you are always going to be at risk for developing C. diff. Because antibiotics can not only kill bad bacteria, it also kills good bacteria, which is what we call normal flora. Normal flora equals our good bacteria. So when we're talking about vaginal bacteria, we have normal flora on our skin, in our mouth, everywhere on our body. And that normal flora protects us. It protects our body. So antibiotics have the capability of not only killing bad bacteria, but our good bacteria, which includes our gut bacteria. If that good gut bacteria dies, you are at a significant risk for C. diff. Okay. Drug-to-drug interactions, synergistic bactericidal effect with penicillins or cephalosporins. So you want to use caution or not at all to put aminoglycosides with penicillins or cephalosporins. Because what did I say? They're related. They're cousins. Okay. Use caution with other nephrotoxic medications. That's basically going to be on every single one of these slides. Almost all antibiotics are nephrotoxic. Okay. And then increased neuromuscular blockade with certain drugs. So it could increase the way that our neurotransmitters work within our nerves and muscles. So true or false, because of the adverse effects of aminoglycosides, it is important to teach the patient to restrict
False.
fluids and eat 6 small meals a day. False. That is false. So you want to provide the following patient teaching. Try to drink a lot of fluids and to maintain nutrition, even though nausea, vomiting, and diarrhea may occur. There are going to be, and I want you to pay attention to these things, there are going to be drugs that specifically say, antibiotics that specifically say, I want you to take them on an empty stomach. And there are others that specifically say that they want you to take them with food. So if we talk about that, I need you to know it. Okay. Any questions about aminoglycosides? All right, so we're going to move on to carbapenems. These are broad spectrum antibiotics. They're effective against gram-positive and gram-negative bacteria. Your most common medications that you're going to see, especially in the hospital, is ertapenem, which is Invanz. You also see meropenem, which is Merum. The other ones you can see, but these two are going to be your most common. So these drugs are bacteria. The way that they kill is to inhibit cell membrane synthesis, leading to cell death. So they change something in the way that the cell membrane is built, which makes it weak. Okay, it weakens that cell wall, and eventually the cell of the bacteria will die. So your indication is the treatment of serious infections caused by susceptible bacteria, treatment of serious intra-abdominal, urinary tract, skin and skin structure, bone and joint, and gynecological infections. So you're going to see some are very specific in where their treatment is, and some cover a very broad area of coverage. Pharmacokinetics, they are rapidly absorbed if given IM and reach peak level at the end of the infusion of if given IV. That is another thing we need to talk about. And I need you to hear me. Peak and trough. Peak and trough. A peak level is when the antibiotic has finished. Okay. I need to go grab my book because I believe it's within 30 minutes of the IV antibiotic finishing is the peak. And then the trough is right before the next dose is due. So there are some antibiotics. One of those antibiotics is called vancomycin. Vancomycin has to have a trough drawn right before the next dose. So about an hour before, because you need the lab to have like an hour to run it and get you that number back. You do not start the next antibiotic before you have your trough. Okay? Because if that therapeutic level is too high, then you're not going to give that antibiotic. If the therapeutic level is too low, pharmacy may increase the dose to make them become therapeutic through their next dose. So I need you to know the difference of a peak and trough. Carbapenems do have the ability to cross the placenta or enter human milk, excreted unchanged in the urine, and the average half-life is 1 to 4 days. Contraindications and cautions. If you have a known allergy, you want to use caution during pregnancy and lactation, and then test renal function regularly.
I have a question.
Yeah.
I'm sorry if you said this. I was writing. So the peak and the trough level, does that only apply to the IV antibiotics, or is that also fall into place when you're taking like an oral one at home? So like your
never,
at like day 7 of your antibiotic when you're done.
no, I have never drawn a peak and trough on an oral antibiotic. They've only been IV.
Okay, thank you.
Yep. So adverse effects include GI tract effects, superinfections, and CNS effects. Drug-to-drug interactions, consider alternative if the patient is taking valproic acid. So that's important to know. Avoid concurrent use of imipenem with ganciclovir. Ganciclovir is an antiviral. And yes, Marissa, they do trough levels for drugs like Keppra, because it's important that the patient is therapeutic with anti-seizure medications. Okay, any questions on carbapenems? Okay. So now we go into cephalosporins. They are similar to penicillin in the structure and activity. You have first, second, third, and fourth generation cephalosporins. Okay. So in your first generation, your most common is cefazolin and cephalexin. Cephalexin is Keflex. So sometimes when they don't have another name, that means that they don't go by a brand name. They only have that generic version. And we're in critically. So the pharmacy or wherever these drugs are manufactured, they don't manufacture a brand name. They only manufacture a generic name. For the second generation, your most common is cefoxitin, just over here. Cefoxitin. Your third generation, your most common is Cefdinir, which is Omnicef. And ceftriaxone, which is Rocephin.
Second generation, I'm trying to catch up.
They're the only common one in the second generation is cefoxitin.
Cefoxitin, okay.
For third generation, you have Cefdinir and ceftriaxone. You'll hear me because I've given Rocephin about 1 million times in my life. You will hear me use this interchangeably, ceftriaxone and Rocephin. It's just, I'm going to try not to, but my brain just likes saying Rocephin, and I've given it so many times that I need to retrain my brain. The fourth generation, your most common is definitely going to be cefepime. And again, just because I'm not telling you that they're common doesn't mean that they're not given. Of course they're given. right? There are always going to be options when it comes to infectious disease. It's always going to be the physician's call on what is ordered. But antibiotics are funny in a way that they're kind of trendy. So at one point in your career, you're going to see that, like in my career, ceftriaxone, Rocephin was very popular. Okay. And then maybe 20 years ago, cefadroxil was very popular. You know what I mean? So you will notice, depending on the facility that you work at, the physicians that you work with, that one antibiotic is very common over the others. Okay.
Do you have a good way to memorize what generation the meds belong to?
Honestly, it's I'm not gonna lie to you, it's difficult. Because they all start with a C. But to be honest, I do not have a good way. Cephalosporins, that's really the one difficult thing about them, is knowing which classification they belong to. And unfortunately, it's something that in this situation, if you do find something like a little jingle or YouTube or TikTok or something, please tell me, or, well, tell me, but like also share it with others, because I would love to have something that would be helpful in remembering this for sure. So cephalosporins are bactericidal and bacteriostatic, depending on the dose and the specific drug. I do not need you to know which cephalosporin of which generation is bactericidal or bacteriostatic. I am not going to get that far into this, especially. They interfere with the cell wall building ability of bacteria when they divide. And the indication is the treatment of infections caused by susceptible bacteria. So basically, any bacteria on a CNS that it shows susceptibility to, we're going to use it. I don't care where it is or what it is, we're going to use it. Okay. So they are primarily excreted unchanged in the urine, eliminated primarily by the liver, and cross the placenta and enter human milk. So what does this mean? We haven't seen this yet. I told you everything's nephrotoxic. What's the difference here? This is hepatotoxic, right? It's eliminated primarily by the liver, which means it's being metabolized by the liver. When things go through the liver, that means that it can be hepatotoxic. If they're only going through the kidneys, they're going to be nephrotoxic. So they're contraindicated in patients that have hepatic or renal impairment. You want to use caution or contraindicate, or they are contraindicated for pregnancy or lactation. And we want to reserve the appropriate situations due to resistance. Cephalosporins are closely guarded. They are not overused. And well, really all antibiotics nowadays are closely guarded. They do not just hand them out freely. There's more patient education nowadays when it comes to resistance. So that's really across the board. And pay attention, allergies to cephalosporins or penicillins, because penicillins and cephalosporins are cousins. Adverse effects include GI tract are most common, so nausea, vomiting, diarrhea, CNS symptoms, nephrotoxicity, and superinfections. Drug-to-drug interactions, there is increased nephrotoxicity risk with concurrent administration with aminoglycosides. So you're probably not going to be giving ceftriaxone with gentamicin. Okay? Aminoglycosides and cephalosporins increase nephrotoxicity. And you also have an increased bleeding possibility with warfarin. Whenever there is a drug to drug interaction for bleeding or anticoagulants, it's important. All right, you are writing a plan of care for a patient receiving cefaclor. What would be an appropriate nursing conclusion for this patient? You know, this question kind of sucks because I could understand why someone would pick monitor renal function. I could also understand that the patient will have an understanding of the drug therapy. Like it makes sense, you know? But this is a good example of when an answer is the most correct out of all of the options. So
Would we say? Oh, go ahead.
So nursing, is that me? So nursing conclusions related to the drug therapy might include impaired comfort related to GI or CNS effects of the drug, superinfection risk, and knowledge deficit regarding drug therapy. Planning includes that the patient will have an understanding of the drug therapy. Performing culture and sensitivity tests and monitoring renal function are assessment and intervention items respectively. So here is, let's look at the question again. This question is asking about the nursing process. It's asking, you are writing a plan. You are in the planning part of the nursing process. All right, so we want to be thinking of ADPI, assessment, diagnosis, planning, implementation, evaluation. So you are writing a plan of care. So the patient will have an understanding of the drug of planning. Monitor renal function tests, that's part of evaluation. Perform culture and sensitivity, that's diagnostic. So when we're looking at questions, this is a very good example for NCLEX style questions. You have to find out, what is it asking me? It's asking me specifically what part of the nursing process I am looking at. Okay. All right. Fluoroquinolones. These are a synthetic class of antibiotics with a broad spectrum of activity. Ciprofloxacin is very common. Cipro. Levofloxacin, which is Levaquin, is very common. And moxifloxacin is common. Ofloxacin is like not rare, but not common. So fluoroquinolones are bactericidal. Their actions, they enter the bacterial cell by passive diffusion. They interfere with action of the DNA enzymes leading to cell death. So they literally passively diffuse. They don't need active transport. They just floop right through the cell wall. The indication, they treat infections caused by susceptible strains of gram-positive and gram-negative bacteria, meaning they are what? Spectrum. They are broad spectrum. They treat urinary tract, respiratory tract, and skin infections. Some prevent or treat post-exposure of anthrax. Remember? Some of you probably aren't old enough to remember. It was like being sent in the mail. That was really crazy. Every time I read this slide, it reminds me of anthrax and what a crazy time that was. Like people were literally scared to open their mail. It's crazy. Pharmacokinetics, they are absorbed from the GI tract, metabolized in the liver, excreted in the urine and feces, widely distributed in the body, crossing the placenta and entering human milk. So they are hepatotoxic. They are nephrotoxic. They can cause C. diff. Boom, boom, boom. They're everything. Contraindications and cautions. Some have warnings related to potential unknown or
Miss Simmons,
lactating
you keep
patients.
breaking up.
Damn it. When did I start? Just now? Please tell me it hasn't been long.
It hasn't been long.
No,
Okay,
it was
good.
like
Yeah, it was
now,
just
right
like
when you
halfway
said-
through the slide 3.
right
Okay.
after you said something about the C. diff, I think.
Okay, because I know that if I break up during class, it's also going to be broken up in the recording. So is it still happening? Because if it's still happening, I need to try to switch over to my hotspot.
No, you're good
Seems
now.
okay right now.
It's like it comes and goes. It'll do it for a few seconds and then you'll be okay for a while, and then it'll do it again and then you'll be okay.
Okay. Well, just know that it will also be in the recording, so I don't want you to miss anything important. So let me know when it happens and if I have to repeat myself. The most important thing that I need you to know about fluoroquinolones, specifically Cipro, is that it can cause acute tendon rupture. See, it says associated with damage to developing cartilage. Acute tendon rupture. So if your patient that's on Cipro tells you, oh man, my leg hurts, you're going to notify a provider. It says it here. Adverse effects. The most serious is tendinitis, which leads to tendon rupture. Peripheral neuropathy, CNS effects, prolonged QT interval. What other common drug causes prolonged QT interval? Zofran. Zofran. So we don't want to give a patient, especially a patient that has prolonged QT, lots of drugs that can cause prolonged QT, right? C. diff, diarrhea, and liver toxicity. So our biggest hitters with fluoroquinolones is going to be hepatotoxicity, C. diff for sure, tendon rupture is huge, and prolonged QT interval, huge. Okay, very serious adverse effects. Common effects include headache, dizziness, insomnia, and depression. And then you have GI and immunological effects. Drug-to-drug interactions, therapeutic effect is decreased with iron salts, sucralfate, multivitamins, calcium or magnesium supplements, and antacids, which means you don't want to take these drugs at the same time that you with your magnesium
You broke
supplement.
up.
Don't want to take them at the same time as what? Sorry, you went out.
You broke up.
You don't want to take fluoroquinolones at the same time that you take iron salts, sucralfate, multivitamins, calcium or magnesium supplements, or antacids. I don't know if I've ever seen. What?
When you say at the same time, do you mean like, here's all my pills here, or I shouldn't be taking
Correct.
those until I'm done with it?
No,
Okay.
you don't get a handful of pills and just pop them in your mouth.
Okay.
Because I have never seen any drug ever that says in the directions to give with an antacid. There are some drugs that say to take with milk. It's a small handful, but 99% of the time, you are never going to take 99. See, there's a variable. 99% of the time, you are not going to take drugs with antacids. So if antacids is one of your answers, I bet you it's the wrong answer. And then drugs that increase QT interval, warfarin or NSAIDs. And remember, I said when something messes with your anticoagulants, that's important. So contraindications and cautions. Some have warnings related to potential serious adverse effects, which we have discussed specifically when we were talking about Cipro and tendon rupture. Any known allergy, not recommended. I feel like I already talked about this. Can I go backwards?
Yeah.
Oh, okay. I'm like, am I crazy? What is a contraindication to receiving a fluoroquinolone? This is very easy.
C.
It is C. Thank you. It is C. Allergy to Cipro. All right. Questions about fluoroquinolones? Perfect. Okay, so penicillins and penicillinase resistant antibiotics. This was the first antibiotic introduced for clinical use. We have natural penicillins and then we have aminopenicillins. So natural penicillins like penicillin G, there's 3 different types, and penicillin B. Penicillin G is mostly given to pregnant women that test positive for what's it called? Strep B.
Group
B strep.
Yeah,
B
group B
strep.
strep.
Yeah.
Yep. And aminopenicillins include amoxicillin, ampicillin, or a combination of medications. Like Augmentin. Augmentin is a combination medication that includes amoxicillin. So if you have a penicillin allergy, you can't take Augmentin because it includes amoxicillin, right? So these drugs are bactericidal. Most of these drugs are bactericidal. Not many of them are bacteriostatic. The action is to interfere with the ability of susceptible bacteria to build their cell walls. The treatment is for streptococcal infections, pneumococcal infections, and streptococcal and staphylococcal infections. Anti-pseudomonal penicillins have the widest spectrum. The pharmacokinetics, they're rapidly absorbed from the GI tract. They're excreted unchanged in the urine, and they do enter human milk. Contraindications and cautions. You want to be very careful for allergies to penicillin or other drugs that are penicillin-like. Like what other drugs? Cephalosporin.
Cephalosporin.
Renal disease, and patients who are pregnant or lactating. Obviously, this is not contraindicated in a patient who is pregnant, right? Because we give penicillin G to pregnant people that are about to give birth for group B strep. Adverse effects include GI tract and superinfections, drug-to-drug interactions, parenteral aminoglycosides. What does parenteral mean? What does para mean? P-A-R, P-A-R-A, para, the medical terminology. Para means around. Enteral, what is enteral?
That mean G-tube?
No. Enteral is the GI tract, right? So if you think about like GI doctors, gastroenterologists, right? So gastro means stomach, enteral means intestines. So parenteral means around the GI tract. That means everything other than oral. Okay, so IV, IM, ointment. It could be eye drops. So there are drug-drug interactions with aminoglycosides that are given in every way except for oral. Any questions about penicillins? Okay. So we're moving on to sulfonamides. These are drugs that inhibit folic acid synthesis. The medications include sulfadiazine, and this is a combination medication, trimethoprim with sulfamexazole. This is Bactrim. Most people have heard of Bactrim. Bactrim is a combination drug. So here's one that's bacteriostatic. It blocks para-aminobenzoic acid to prevent synthesis of folic acid in susceptible bacteria. So bacteriostatic means that it slows or stops the progression of the cell. These bacteria need folic acid to survive and reproduce. So these drugs are stopping that from happening. The indication is the treatment of infections caused by gram-negative and gram-positive bacteria, which means they are broad spectrum. They are inexpensive and effective treatment for UTIs and trachoma, which means there's probably a very large population or bacterial population that is resistant to Bactrim because it was probably used so much due to being inexpensive and effective for UTIs. What is one of the most common infections in the US? A UTI. So if you're throwing Bactrim at every single human that has a UTI, guess what? You're just asking for bacterial resistance. So the pharmacokinetics, they are teratogenic.
Yeah.
What does that mean?
Can't take
Taking
away
from
pressure.
fetus.
Fetus deletus. That means they are contraindicated for a human that has a fetus. Fetus deletus, baby. No good. That will harm. Bactrim literally gave me permanent GI damage. That sucks. I'm very sorry. Bactrim's the worst. I believe you. So it is distributed into human milk, absorbed in the GI tract, metabolized in the liver, excreted in the urine, which means it is hepatotoxic and nephrotoxic. Contraindications and cautions. Obviously, we are not taking these if we have a sulfonamide allergy, but look at these. It's also contraindicated if you have an allergy to thiazide or loop diuretics, which means your patient can't receive what? Hydrochlorothiazide and furosemide. And what's another loop diuretic that's common? Bumethidine, which is Bumex. Absolutely. Contraindicated in pregnancy and lactation because it is fetus deletus. Renal disease and or history of kidney stones. And you want to be, this is one of these situations where we are very cautious with our older population because of the decreased renal function. This is probably, if I looked up the Beers criteria, I can almost guarantee that sulfonamides are on there. Adverse effects include GI effects, renal effects. We already know that it's bad for the kidneys. CNS effects, bone marrow depression. What does that mean? What is it doing?
Blood dyscrasias.
Yeah, well, so I'm mostly talking about immunocompromisation.
It's making them
weaker.
weaker.
If you're depressing the bone marrow, then that means that you are depressing your immune system. Okay. And then dermatological effects is like skin rash. And I think somebody put in the chat Steven Johnson syndrome. 4 S's of sulfas: sour stomach, sunburn, stones, and Steven Johnson syndrome. Thanks, Marissa. Would you guys like me to repeat that? So the 4 S's of sulfas: sour stomach, sunburn. This is called photosensitivity. Photosensitivity, when you're more susceptible to sunburn because of an antibiotic or drug. Photosensitivity. Stones, she's referring to renal stones, renal calculi. And then Steven Johnson syndrome, which is a dermatological adverse effect. Thanks, Marissa.
You're welcome.
Drug-to-drug interactions, anti-diabetic drugs, drugs that increase hyperkalemia risk. I was upset about the question on your exam today talking about the hyperkalemia risk. What is a drug that puts your patients at risk for hyperkalemia?
Potassium sparing.
It is a
Steroid.
antihypertensive. It
Oh.
is
Lisinopril. Lisinopril. I got that one right.
lisinopril.
I know I did.
Lisinopril. This is a classic NCLEX question. Okay, I need you to remember this. Lisinopril puts your patient at risk for increased potassium hyperkalemia, which you would want to question if your patient was also on spironolactone, which is a potassium sparing diuretic. So if sulfonamides increase your risk for hyperkalemia, we also don't want to give them with other medications that increase your risk for hyperkalemia. Okay? And cyclosporins. We'll get there. All right, let's take 5 minutes. Because we have less than an hour, I just need to eat and come back. So 5 minutes, I want to grab my book because I don't have it. And I'll be right back.
Quick question for students. I was just wondering, do you guys have a method to keep up? I keep falling behind.
June, just cut your transcript on and read through the transcript.
Oh, okay.
drop our grade if we only get level 1.
Yeah.
Miss Simmons,
Yep.
we were just talking about how it's 20, something like that, 20 chapters. Girl,
I know. I know. I know. I'm panicking. I told you, this might be a situation where I pre-record and send you a lecture. I might have to. I really might have to. This is why I do not like Monday, Tuesday classes. I need Monday, Wednesday, because there needs to be time in between your class, your lecture, and your exam, so you guys have times to study and all the things. Because the last day of class, I want to be through everything so that we can review that entire day. That is my goal. So I'll figure it out, believe me. All right, moving on. Okay, tetracyclines. They were developed as a semi-synthetic antibiotic based on the structure of a common soil mold. Your most common are going to be tetracycline, doxycycline, that's not it. But they all end in cycline. Okay? Cycline. There's going to be important things about both tetracycline and doxycycline. So tetracyclines are bacteriostatic. They inhibit protein synthesis in a wide range of bacteria, leading to the inability of bacteria to multiply. They are toxic to humans at high concentrations. So we're not giving crazy amounts of these. Did she leave? Oh, okay. Did she sign out? Can you check?
She did.
Indications include treatment of various infections caused by susceptible strains of bacteria, infections when penicillin is contraindicated. So this is like if penicillin was like the #1 guy that you wanted to use, tetracyclines would be your backup. They are absorbed adequately from the GI tract. They're concentrated in the liver, excreted unchanged in the urine. So hepatotoxicity, nephrotoxicity, crosses the placenta, passes into human milk. Contraindications and cautions, obviously allergy to tetracycline, pregnancy and lactation, and children younger than 8 years old. That is definitely a zebra. On page 124, under contraindications and cautions, it says tetracyclines should be used with caution in children younger than 8 years of age because they can potentially damage developing bones and teeth.
Are those also the ones that can discolor their teeth?
Yes.
Okay.
So, adverse effects. I'm literally looking straight from the book. GI tract, nausea, vomiting, diarrhea, abdominal pain, glossitis, that is inflammation of the tongue. Dysphagia, difficulty swallowing. Fatal hepatotoxicity. Skeletal effects involving damage to the teeth and bones. Because tetracycline has an affinity for teeth and bones, where they accumulate, weakening the structure and causing staining and pitting of the teeth and bones. That is very important. Sensitivity, which is the sunburn that we were talking about with sulfonamides.
Is this all on page 124?
124 and 125.
Okay.
Drug-to-drug interaction includes concurrent tetracycline use. You don't take 2 tetracyclines at once because they can be toxic and kill you if you take too much. Oral combinations that decrease absorption. This specifically says to administer on an empty stomach. I want you to hear me, hear the words that come out of my mouth. If you drink a glass of water, does that mean you ate food? Is that the same thing? No.
No.
No. So administer on empty stomach with water. If something says that your patient took doxycycline with a glass of water, I need you to understand that that does not mean that they didn't take it on an empty stomach. Empty stomach with water is still empty. Okay? Bless you. Okay, I have a star. On page 125, major adverse effects involve direct irritation of the GI tract, include nausea, vomiting, diarrhea, abdominal pain, glossitis, dysphagia. You're supposed to take on an empty stomach with 8 ounces of water. If gastric distress occurs, patients can take with a small amount of food, even though this decreases absorption. Now, it is preferable that it is taken on an empty stomach. Anybody ever taken doxycycline? Makes you want to vomit.
I just finished a script of that, like literally 2 days ago.
Yeah, literally makes you want to vomit in the sink. It's almost impossible to take doxycycline on an empty stomach, which is crazy that you should take it on an empty stomach. Most people do not know this, but it's important to know that it decreases the absorption of the drug if you take it with a large amount of food. I don't see Rachel in my waiting room.
I'm gonna try to send her the link to her phone. For some reason, it kicked her out and she can't get it to go back on.
Oh, that's weird.
Yeah.
Well, you'll have the recording today because this is a short one. True or false? Sulfonamides should not be given with cyclosporine. Is true. Sulfonamides are when sulfonamides are taken with cyclosporines, the risk of nephrotoxicity increases. All right, antimicrobacterials, mycobacterials. Mycobacteria include pathogens causing TB and leprosy. The first line drug for treating tuberculosis is isoniazid, rifampin, pyrazinamide, ethambutol, and rifabutin, and rifampicin. Jesus, that was a hard one. But specifically, it's very important to know about isoniazid and rifampin.
What is isoniazid abbreviated? What's the letters they use? Is it IN? What?
I do not see an abbreviation in the book.
Okay. Maybe I'm getting that confused with something else then.
Yeah, I do not see an abbreviation in the book. So one thing that's really
Rachel
important.
asked if you're able to let her in. She said she's in the waiting room. Sorry.
It's okay. The important thing to know about TB drugs, anti-TB drugs, is that you're not just taking one. You're taking multiple anti-tuberculin drugs at the same time for months. months. Compliance with the drug regimen with these drugs is so important. Patient education is huge when it comes to these drugs with TB. Okay, very, very important. So most act on the DNA of the bacteria, leading to lack of growth and eventual bacterial death. The indication is to treat TB and leprosy. They are generally well absorbed from the GI tract, metabolized in the liver, excreted in the urine, crosses the placenta, and enters human milk. Oh, wow. Contraindications and cautions, obviously an allergy, severe renal or hepatic failure, pregnancy. Adverse effects include CNS effects and GI irritation. You want to be careful with combination of drugs that increase the risk of hepatotoxicity because these drugs are hepatotoxic. It says CNS effects such as neuritis, which is inflammation of the nerves or neurons, dizziness, headache, malaise, drowsiness, and hallucinations are often reported and related to direct effects of the drugs on neurons. This is on page 130. This is important. The drugs that start with R, the first one, which is your most common one, rifampin, and then the other two, rifabutin and rifapentine, cause discoloration of body fluids from urine to sweat and tears. Alert patients that in many instances, orange-tinged urine, sweat, and tears may stain clothing and permanently stain contact lenses. This can be frightening if the patient is not alerted to the possibility that this will happen. Concurrent use of isoniazid, rifampin, and or pyrazinamide increases the risk of hepatotoxicity. This is also important. Eating foods with tyramine and taking isoniazid can cause a histamine reaction, causing headache, diaphoresis, or flushing. Taking isoniazid with alcohol use can also increase the risk of liver damage. So there are a lot of drug-to-drug interactions on page 131 that are pretty important. And they are more important because when you look at the longevity of treatment, I told you this is not just a week. This is months of treatment for these patients. So patient education is huge. This is just looking at other antibiotics that they don't really go in depth about, which I think it's pretty absolutely crazy that they don't go in more depth about macrolides and lipoglycopeptides. Lipoglycopeptides includes vancomycin, which is a very common antibiotic. The thing that I want you to know about vancomycin, vancomycin is the gold standard for treatment of C. diff, but not IV, oral. The treatment of C. diff has to be oral vancomycin. Because where is C. diff? in your gut, in the GI tract. Vancomycin, if given IV, doesn't do anything to the GI tract. So in order to treat C. diff, vancomycin has to be taken orally. When your patient is taking IV vancomycin, they have to have a peak and trough because vancomycin has a therapeutic level and a level of toxicity. It has to be within its therapeutic window for IV vancomycin. They do talk about the lipoglycopeptides, which includes vancomycin on page 134. Vancomycin is the only one in this category that has an oral form. Lipoglycopeptides, listen to the words in my mouth, reach peak levels at the end of the infusion. So when I ask you, when is the best time for you to have a peak vanc level drawn, you're going to tell me at the end of the infusion. I think that's my chat, my Google chat, making all these noises. Macrolides. Macrolides include erythromycin, azithromycin, which is Zithromax. Those are both common antibiotics. You want to use cautiously in patients who are lactating because macrolides are secreted in human milk and can cause diarrhea and super infections in the infant. And in patients who are pregnant because of potential adverse effects on the developing fetus. Use only if the benefit clearly outweighs the risk to the fetus or the infant. That's on page 135. With these drugs, you could have increased serum levels of digoxin. That starts on page 136. When digoxin is taken concurrently with macrolides. Patients who receive both drugs should have their dig levels monitored and dose adjusted during and after treatment with macrolides. And I think that's all I care about for chapter 9. Am I going backwards? Oh. All right, chapter 10, we start talking about antivirals. Viruses have a lot of characteristics that bacteria do not have. They cause a variety of conditions. Single virus particles, either there's DNA or RNA in a protein. Viruses cannot survive without a host. They can survive for a while, like on a doorknob, a table, some hours to days. But they cannot replicate without a host. So, like that says, the virus replicates in the host cell. It has to have a host to replicate. The host cell dies and releases new viruses into the body. So, if the virus invades one of our cells, it replicates inside of that cell. Okay? And then there's a bunch of little viruses inside of that cell. When that cell dies, all of those little baby viruses are then spread out to the body. Okay? It's like a pregnant spider. When you kill it and then all of a sudden the baby spider's just like, literally my worst nightmare. My worst nightmare. I would die. Okay? They are difficult to develop. It's difficult to develop effective drugs that destroy a virus without harming the human host because they literally go inside of our cells. Interferons released by the host act to prevent replication of the virus. We try to fight viruses. Eventually, we do fight viruses. But as smart as bacteria are, viruses are a lot smarter. A lot. So the stages of viral replication, you have a virus that adheres to a cell. It enters the cell. The virus starts breaking down and replicating its DNA. It replicates the nucleic acids. It encapsulates those proteins so that they can survive. They make new cells. So one cell literally turned into 1, 2, 3, 4. And then when the host dies, it releases them. Okay. So antivirals for children. Children are very sensitive to the effects of most antiviral drugs, and many drugs have no proven safety or efficacy. We don't really give antivirals to children. Okay. Adults need to know antivirals are specifically for treatment of viral infections. We do not treat them with antibiotics. We only treat viruses with antivirals, and most of the time, we don't even treat viruses because we need to let them run their course. How many times have you heard that from your physician or whoever? Oh, it's a virus. You need to let it run its course. Okay. It has significant adverse effects on fetal development, so we do not give it to humans carrying fetuses. Older adults may be more susceptible to adverse effects, and you want to be cautious with hepatic or renal dysfunction. So agents for influenza A and respiratory viruses, the best option is prevention. So we always want everyone to be vaccinated, all the vaccinations for everyone and all their babies, right? So we also know that the flu virus changes every year because what did I say? Viruses, are very intelligent. So we have to change the flu vaccine every year with the changing flu virus. And we never actually know whether that flu vaccine is going to be successful, which is very scary. And also is annoying that we all require it because you don't even know if it works. I am not anti-vax, by the way. My child is vaccinated against everything. I am very pro-vaccination, but I also don't want to inject something in my body that we don't even know if it works. And I also had an allergic reaction to the COVID vaccine, so I am tainted. So, the action, it inhibits enzymes, slows the spread, or causes viral death. Pharmacokinetics varies by particular drug. Contraindication, oseltamivir is contraindicated with renal dysfunction, pregnancy, breast, or chest feeding. Adverse effects may be related to the effects on dopamine, which is a neurotransmitter. Drug-to-drug interactions, the nasal influenza vaccine and neuroamidase. I don't care if you know that. What I do care if you know about nasal flu vaccine is that it has contraindications. If your patient is immunocompromised, we do not give them live vaccines. The nasal flu vaccine is a live virus. We do not give live viruses to patients that are immune compromised. Also, where is it? It is on page 147 in box 10.1. I think. No, I want the vaccine. Ooh, ripped it. This is important, and I don't remember what page it's on. I'm pretty sure it has, you can't give it to anyone older than like 65. Or I think kids younger than some age. It's gonna come up in one of these pages. I know it is. I just don't remember which page it is. And apparently it's not this chapter. So, true or false, treatment of a viral infection is difficult without serious toxic effects for the host.
True.
It's true.
That is true. So a virus must enter a human cell to survive, making it difficult to treat without serious toxic effects. Drugs for herpes and cytomegalovirus. They inhibit the viral DNA replication by competing with viral substrates to form shorter, non-effective DNA strains. Just a very fancy way of saying that it gets in the way of replication and DNA synthesis. So they're contraindicated. Some drugs are highly toxic. Extreme caution in pregnancy or lactation, known allergies, renal disease, CNS disorders. Adverse effects include nausea, vomiting, headache, depression, paresthesia, neuropathy, rash, hair loss, renal dysfunction. And you want to be careful with other nephrotoxic drugs. And zidovudine, which is a HIV drug. So that starts on page 149. So some drugs indicated, this is on page 150, some drugs indicated for the treatment of herpes and CMV are highly toxic. They should only be used during pregnancy or lactation if the benefits clearly outweigh the potential risk to the fetus or infant. Avoid use in patients with known allergies, of course, renal disease, severe CNS disorders, because the drug can cause CNS effects, causing headache, neuropathy, paresthesia, confusion, hallucinations. Ganciclovir, which we talked about with one of the antibiotics. I don't remember which one. has been associated with bone marrow suppression, but it was contraindicated for one of the antibiotics we talked about, ganciclovir. I don't remember which one it was. Oh, I think it was the aminoglycosides. The risk of nephrotoxicity increases when agents indicated for the treatment of herpes and CMV are used in combination with other nephrotoxic drugs such as the aminoglycoside antibiotics. That's probably what it was. Agents for HIV and AIDS. These are called antiretroviral agents. You have multiple different types of HIV and AIDS drugs. NNRTIs, and then you have NRTIs, protease inhibitors, fusion inhibitors, CCR5 or receptor antagonist. So when you are thinking about HIV/AIDS, the point of these antiretrovirals is to decrease the viral load. Okay? When you have a high viral load with HIV, you then have progression to AIDS, because also you have what's called opportunistic infections. Because what HIV and AIDS does is that it attacks your immune system. Okay? So if you have a very high viral load, you become severely immune compromised and you get opportunistic infections. Those opportunistic infections include Kaposi sarcoma. It can include TB. Special type is an opportunistic infection with HIV.
Can you repeat those first two? Because you kind of broke up again.
Yeah, we get a really adequate list here. This infection. So common opportunistic infections with HIV include toxoplasmosis, cytomegalovirus, which is CMV, which we just talked about, antivirals for herpes and CMV, herpes simplex virus, which is HSV, meningitis, candidiasis. Candidiasis, which is an overgrowth of yeast, is always going to be a risk when a patient is immune compromised. So when you have a low CD4 count, you guys have learned about HIV, correct? She's
Yes.
like, no. So with HIV, you have what's called CD4, which are your T cells. They're part of your immune system. When you have a low CD4 count, and you do not take your antiretrovirals correctly, and you have opportunistic infections, that is what progresses you to AIDS. Just because you have HIV doesn't mean you have AIDS, okay? AIDS is a progression of the HIV virus. So antiretroviral therapy is, for short, they call it ART, A-R-T, antiretroviral therapy. And that treatment is either one of these drugs or a combination of these drugs. The most important thing about HIV and the is extreme. They cannot miss their meds. They have to take their meds every day.
That what was that extreme what? You broke up on my end. I'm sorry.
I don't know. What did I say? Extreme what? I don't know what I said.
Extremely compliant.
Oh, extremely compliant. They need to be extremely compliant with their medication regimen. It's very important. So the NNRTIs, they bind directly to HIV reverse transcriptase. They block both RNA and DNA dependent DNA activities. They are rapidly absorbed from the GI tract, metabolized in the liver. They are contraindicated or also just very cautious with pregnancy and lactation. Adverse effects are GI related, but could include dizziness, blurred vision, headache, flu-like symptoms. Drug to drug. Delavirdine, which is a HIV drug, has interactions with antiarrhythmics, clarithromycin, anti-TB drugs, calcium channel blockers, warfarin, quinidine. So you have to be careful with those. Efavirenz has an interaction with midazolam, which is Versed. And then St. John's wort. St. John's wort is an herb. It's a common herb. We're actually going to talk about that when we get to GI because there is a lot of drug-to-drug interactions with St. John's wort that is classic NCLEX. So the NRTIs, they can compete with naturally occurring nucleosides within the cell. They're rapidly absorbed from the GI tract, metabolized by the liver, excreted in the urine and or feces. So you want to be careful with the patients that have hepatic dysfunction if they're metabolized by the liver. Adverse effects include hypersensitivity, pancreatitis, hepatomegaly, neurological problems, and bone marrow suppression. Protease inhibitors, they block protease activity to render the HIV particle unable to fuse with and inject itself into the cell. You have to be very careful with hepatic dysfunction and treatment with anti-diabetic drugs. All of these drugs, most of these drugs, not all, most of these drugs are hepatotoxic. So you have to be careful with these drugs and hepatotoxicity or hepatic dysfunction. Fusion inhibitors, so anything given sub-Q, you have to remember it can cause a injection site reaction. CCR5 core receptor antagonists. Adverse effect includes severe hepatotoxicity. So really the trend here is hepatotoxicity. It's a huge trend with antivirals, antiretrovirals specifically. Again, adverse effect, liver failure, renal impairment, suicidal ideation. That is a zebra. We haven't seen that yet. Drug-to-drug interactions decrease serum levels of combined with rifampin. Rifampin is a TB drug. TB is an opportunistic infection for HIV, people that have HIV. So if they take one of these drugs, it can decrease the effectiveness of rifampin if they contract TB and St. John's wort. So you're caring for a patient who has been diagnosed with herpes simplex and is given a prescription. What should you teach this patient about taking their medication?
C.
The answer is C. start taking the medication as soon as possible to improve the effectiveness of antiviral activity. So administer the drug as soon as possible after the diagnosis has been made to improve effectiveness of the antiviral activity. People that have oral herpes simplex virus or genital. Genital is usually they take it daily. They take something daily, an antiviral daily. A lot of people that have oral herpes only take something when they feel that tingle. I've never had a cold sore, but my dad gets them. And he says that you always feel it like the day or two before it comes. It's like this tingly sensation. And he automatically knows that one is coming. So people that deal with this, usually they feel that sensation and they automatically start taking their antivirals so they can shorten the span of their cold sore. And they also have topical things like what's it called, Abreva. You are caring for a patient with HIV. The patient says they are experiencing pain at the site of injection. What type of drug is the patient taking? It was the only drug on this list that was sub-Q.
B.
The answer is fusion inhibitor. The fusion inhibitor is given by subcutaneous injection. A potential adverse effect is injection site reaction. So remember, this is the only drug for HIV that's given sub-Q. Anti-hepatitis B agents. So they inhibit reverse transcriptase in the hepatitis B virus. They are contraindicated with known allergies, renal impairment, severe liver disease, pregnancy, and HIV infection. Pretty much all of these antivirals are used cautiously or contraindicated with liver dysfunction or liver failure because of hepatotoxicity. There's increased risk of renal toxicity if these drugs are taken with other nephrotoxic drugs. Hepatitis C. Fun fact, hepatitis C is now curable, which is very nice. So if you contract hepatitis C, it is no longer a lifelong virus. So adverse effects are headache, fatigue, nausea, diarrhea, rash, severe skin reactions. There are toxic effects or loss of therapeutic effect with other protease inhibitors, and it also has a interaction with St. John's wort. I want you to do something for your key points. I want you to make a list specifically for St. John's wort on what drugs have a drug-drug interaction with this herb. It will be very helpful for you. Locally active antiviral agents, they act on the virus by interfering with normal viral replication. They are for very specific local viral infections. They're not absorbed systemically, but use caution with known allergies, and you don't want to apply these to open wounds. So they can cause local burning, stinging, and discomfort. So this is a topical. Which antiviral drugs are not absorbed systemically? It's just on the last slide. B. Locally active antiviral agents. They're not absorbed systemically. They are only local. So this would be your Abreva, right? The little thing you can buy for cold sores that you just put it on topically. Okay. So that would be only for like a local virus, not systemic. Okay. What I would give for another hour, you know?
Google says you can't give the nasal spray flu vaccine to anybody over 50.
50. Okay, so Google says you can't give the flu nasal vaccine to anyone over the age of 50. CDC.gov, not just Google.
I think it's under 2 for the kids as well.
Yeah, I think it is too. Under 2 years of age or over the age of 50. I'm telling you, that's going to come up somewhere. I need you to know that. For anybody who's do you want to be careful with aspirin and salicylates? It's coming because we have a whole chapter on vaccines.
But
Hmm?
so a lot of information.
A lot of the chapters are really short. But it's a lot. So antifungals is not a lot. Antiprotozoals is not long. There's only really a couple of key things in there. Anti-helminic, there's really only like a small amount of information that I want you to know in that chapter. Anti-neoplastics, this is all about cancer treatment. It's really all about how you help your patient. Patient education is huge for chapter 14.
Or lectures we need to watch.
Oh, yes. Yeah. Yeah, chapter 15 through 18 is all about the immune response and inflammation. So, NSAIDs, steroids, huge on steroids, really, really big on steroids.
Yeah. Same with these.
Yeah.
Tonight's gonna be homework tonight after bowling.
Yeah, then we have RA, MS, a lot of autoimmune situations. DMARDs is a huge one. Immune modulators, that one is, there's not going to be a lot on immune modulators. Vaccines and Sarah. Vaccines, there's not going to be a lot. So you're going to go over vaccines, like when kids get vaccines, a ton in peds. So I am not doing vaccine schedules. Nope. It's going to be very specific, important things to know about vaccines, and that is it. And then we go to GI.
That's a lot.
There's so much. No.
So do you think we will get the lecture before Monday?
Listen, guys.
Since
If you guys keep asking me the same question over and over again when I've answered it 16 times, I'm going to fight you. I am absolutely going to pre-record a lecture and send it to you. I've said this 5 times already.
So we'll get the lecture on Monday?
Oh, you're going to get the lecture in your email. He's laughing. I'm going to fight you, Corey. Ha ha ha.
Do you know what percentage of new information will be on the final?
So the final is going to be at least half new. And so probably about 60% new. And the rest is going to be stuff we already covered. That's I mean, you guys should be used to that. That's standard.
Yeah. That's
Oh, I didn't know it was standard, so sorry.
Oh, well, at least it should be. It should be.
I mean, it's been that. I didn't know that was the standard it
Monday to
was.
go over
She said
our
that
old
makes me want to
test?
cry myself to sleep.
Tammy did that work. All we had. I'll get on up the bus and take him with me to.
Hold on one second.
You can go with your brother and your son.
Have just the best week.
I'm gonna get all my homework done.
Yay.
Yeah.
No, we can do this, guys. We've made it this far. You gotta think after this.
I might cry too.
We made it this far. We can go on vacation.
I'm also ready for that 2-week vacation.
While we're
2
off
weeks
topic,
when?
I had a meeting.
Yeah, I would also like to know.
The end of December. Our last term in December ends on December 19th, and we don't come back until January 5th. Yeah, she's Dan.
I had a meeting scheduled with you at 1.
I know, I saw that. Yeah, I saw.
I just picked the soonest date, so I wasn't even paying attention.
we can stay on, Corey, actually, I'll exit out of this because I don't want it recorded with everybody else's stuff, and then we'll start a new one. And then I think I have another one with somebody.
I did. I had one with you at 2.
I have another appointment with him at 3. So
Okay.
he's pretty sick.
If we've got a little bit of time, can we do like the exam review now at least and get that out the way? Because don't we have class till 2:30?
2:00 today.
No,
Class is at
they
2
told me
o'clock
2
today.
o'clock.
Oh.
Oh, well, then I could stay.
2:30? Oh, okay.
Oh, I didn't know that.
I was gonna say, if they lied to me, I'm gonna go chase after them. I'm gonna be
Oopsie,
mad.
my bad. My bad.
It's okay.
Miss Simmons, I have a question.
Hold on one second. I cannot go over the exam review on a recorded line. So it would have to be exited out of this, and it also has to be with the I have to give the option. If I'm going to do a huge group like this, it has to be an option with the rest of the class too. But also, what I'm going to do is, what clinical days do you guys have this week? My group is Thursday.
Aaliyah has Friday.
Tomorrow.
We have it tomorrow for Sylvania A, but then Sylvania B has it next Thursday. It's all messed up.
Tomorrow for Niles.
Oh my god.
Yay.
And then, Jess, did you just want me to cancel? Because our meeting was at 2.
Okay. No, I mean, unless you have something to do, I can meet with
No,
you.
that's okay.
right
I
when
just
we're done,
didn't know if you
Rochelle.
wanted to get Corey out the way first.
It's up to
or-
you. Do you?
Mm-mm.
Do you?
I just didn't know
work
if you wanted to
something?
get Corey out the way first.
Oh no, I think he said he has an
Okay.
appointment.
I don't mean to
I think he said he
overwhelm
has
you.
an appointment.
Well, Miss Simmons, I'm gonna
I
log
do
off
at
now.
3, but if
will,
I thought we
email you.
had class till 2:30,
Oh,
Thank
okay.
you.
so I can.
Okay. Corey, let's go ahead. Rochelle,
Sure.
I'll meet
You
I
cut
can
out.
just hop
after.
back on
You
at like 2:30.
Oh, I'll meet
cut
with you.
out.
Okay. Corey, I will meet with you right now. I'm gonna end this and then restart a new one.
Okay.
Okay, and
Are you
then,
gonna invite me or?
no, just go right back to the Ring Central link.
Okay.
And then Rochelle, I'll send you
Sounds
an
good. Thank
email
you.
as soon as I'm ready for you. You're welcome.
Miss Simmons?
Ah.
Are you able to explain to me the ATI? Because on our syllabus, it says like the 10%, and that's just for like the proctor. So I don't know if I'm just like reading it wrong or.
So this is supposed to fix the way that the ATI proctored exam drops your grade, like how it used to drop your grade, right? Because the proctor is worth 8 out of okay, so if the ATI, if we're looking at the ATI in total, the practice, and the proctored is all 100 points. Okay, let's just imagine that. That first practice is 10 points. That second practice is 10 points. And then the proctor is 80% of that 100%. Okay. So the way that she did it was that the practice test was worth 1 point. The other practice test was worth 1 point. And then the proctor is worth 8 out of 10. so that when I put that grade in, it doesn't automatically just drop you 3-4%. Because previously, the way that it was false grade, the practice tests were taking up, were not balanced correctly. I mean, they were balanced, but they weren't balanced in a way that it would show you like a false percentage. So all of a sudden, if you got a level 2 with a 65 out of 80, it dropped you 4%, and it was like, oh my God. And how do you plan for that? How do you plan to drop 3-4%? You can't. So it was a huge issue. Not that it was wrong, but not that the math was wrong, because the math was not wrong. It was just the way that it was being presented with the percentiles. I feel like that sounds really complicated, and it makes my brain hurt.
I feel like that makes me really sad.
I put the new scoring. I put the scoring in the chat because that's what I was told. The new and it's on the ATI. I mean on the Ross Brightspace.
That's what's on our syllabus. That's for the
Yes,
proctor.
so it was
that is specifically for the proctor, right?
Oh, so it was that not what you was talking about?
Hold on.
Sorry.
I need to look at this.
No, our syllabus says something totally different.
Yeah, the syllabus says the proctored assessment with remediation, level 3 equals 80 points, level 2 equals 65 points, level 1 equals 50 points. Yeah,
I think it's after, like, with remediation, you get more points back after doing, like, that gets added in. Because for
No.
the fundamentals one,
that's
so
including.
it's not like that anymore?
No, that score is including your remediation.
I thought it was changed. I thought that was the new scoring down at the bottom
Time
where
out.
you get more points.
Time out.
Okay.
Yeah, because I got a level 2 on the fundamentals one, and it told me I had an 85, like, was my overall grade after remediation.
So I was told, I don't know if this is what she was going to confirm, but I was told that basically they changed the scoring. They made it to where they're not calculating practice A and practice B. And the proctor is within itself out of 100 points. So you get if you were to get a level 1, you would get the 55 points. If you were to get a level if you were to get below a level 1, you would get 55 points. Level 1 70 points, level 2 85 points, and level 3 100 points. Before whether you were only getting 80 points for the level 3, but then they were calculating in the practice A and practice B. It was like really weird.
All right, Christy's gonna come in here and explain this because she did it, and I don't know what she did or how she did it. So yeah.
I guess worst case scenario, how many percentage points is able to drop?
Girlfriend.
Like say you only get like a level 1, because before it would drop like 4 or 5 points.
I don't know. She needs to answer this. Did you turn off scheduling for your calendar? No, I didn't. You
So
know
I
what?
just found it on our syllabus. It does, so they did change it. The proctored assessment with remediation is worth 80 points. A level 3 is you get 80 points. Level 2 is 65. Level 1 is 50, and below a level 1 is 0 points.
So
That
this
was
is,
what it was before.
yeah, this is the way that it's always been for every class I've taken. Or every class that
So before with the, like I said, with when I took it in fundamentals 1, I got a level 2 and I got an 85 because they did it out of 100, but it looks like now they're only doing it out of 80. So maybe that's why it
Because-
looks a little bit different.
Right, because the percentages are the same. Like it's still out
Yeah.
of like, well, like I said, 100%, but the proctor is
Mhm.
worth 80 out of that 100.
It's because it's out of 80 points. Yeah. So like if I get a level 2 again, I'd get 65 points.
Yeah.
Yay.
And just to make sure, if you get 65 points, that would be 6.5% out of 10.
Hold on. She's walking in here right now. The floor.
So that would put you at an
Dr. Vogel,
81. If you got a level 2, you'd get an 81% on
explain
it.
to our friends here. Hello.
All right, so you guys are confused on the grading scale of the ATI examinations, correct?
Yes.
Okay, so they have been changed this month to help kind of reduce some of that anxiety. So your practice test A is a pass complete. So there's no points associated. You have to do it and you have to do the remediation in order to take the proctored exam. Okay. And then your proctored exam is now worth 100 points, which is worth 10% of your overall grade. Therefore, it won't give you that false grade. So when you take the exam, it'll drop your score massive amounts. That's why we changed it to that pass fail. So there, nothing has changed. It's still worth an overall 100 points. And that 100 points is worth 10% of your overall grade.
So a level 3 is an 80 out of 80. A level 2
No, it's out of 100 points. So a level 3 is 100 out of 100 points. You get 100% if you get a level 3.
That's not what it says on the syllabus.
Let me
Our
look.
syllabus says.
Okay, let me look. I am human. I may have made an error and I'd be more than happy to change that. So let me look. Where's that?
It says it under the assignment. So if you go to the actual assignment for the ATI proctor, it says it at the bottom.
No, not that. Open this. Open what? Like max. Yeah, there it is. Right there.
Okay, so the syllabus is incorrect. I must have missed that. So the syllabus should say practice test A as a pass fail that it must do. Practice test B pass fail you must do, and then level 3 would be 80 or 100 out of 100 to equal 100 points. Okay. A level 2, I have it all figured out. So let me get it figured out for you and then I will post it and I will also post it into an announcement. Let me look in one more place real quick to see if I have to change the grade book as well.
So how much
this
could it
this can
potentially drop our grade?
Hold your questions.
Go ahead and ask. Go ahead.
Okay.
So how much
So-
could it potentially drop our grade?
It won't drop.
If we got
That's
a
what I'm
level one.
saying. It after I make the corrections, it should not drop your grade at all.
The ATI won't drop our grade at all anymore, is what you're saying.
If you get a level 2 or a level 3, it should not drop your grade.
So the way that the ADON explained to me is basically a regular exam. It's calculated as a regular exam, except for the simple fact if you get a level 1, you get a 70. A level 2 is at 85, and a level 3
That's with the
is
old
at 100.
curriculum. That's with the old curriculum. It is now written out of 100, and it is not correct in your grade book. So I will get all of that switched over. That
Okay.
is my error.
So say someone
100%.
got a level 1, how much would, like, what percentage approximately would their grade drop then?
I can't give you that. It would be different for every single grade.
Really quick, I just want to read off what this says, just to make sure. It says
You want to
level
read
3,
off
100%.
what says?
Oh, it proctored assessment with remediation.
From where?
It just says level 3, 100 points, level 2, 85 points, and level 1, 70 points. Is that accurate?
I don't know. I don't know off the top of my head. I'm trying to figure that out for you. Where did you get that?
I went to under week 4 in Brightspace for our class. I went all the way down toward the bottom of the page. It says ATI proctored exam with remediation. I clicked on that. I scrolled down to the very bottom, and
Yeah,
there's
right there. That's the correct syllabus. Correct. That is the correct.
Right. That's what I
rubric.
said from the very beginning. So I'm confused now.
Oh, okay.
So this is the correct
So a
one.
level 1 would give us a 70%.
A level 1
Is
would
what that-
be 70% because you're required in the courses to get a 76% to pass. So it used to be, oh, sorry. Hold on one second.
She's right there.
No, I'm clicking buttons. That's me.
Oh,
Sorry.
Huh?
Sorry.
Okay.
You guys. So yes, so under week 4, that is the correct rubric. That will give you the correct scores from what you get. Okay. So now if you get a level 1, it shouldn't completely fail you based off of the level 1 because we require you to get a level 2 in our program because that's what NCLEX and ATI says that you're competent to pass the NCLEX. So you do still fail that portion of the course, but it won't fail you in the course if you don't get a level 2.
So you won't fail the class essentially if you get less than a level 2.
unless you're sitting at a low grade.
Unless you're sitting at a
yeah.
low grade, if you go into the test with a 76% and you get a 7 or get a level 1, it will fail you because you failed the test.
Yeah.
Correct.
Yeah.
So it's all going to be dependent. It's on a weighted grade system. So I can't give you the information that you're going to pass if you get a level 2. So it's designed to be a passing score with a level 2.
Okay.
And you said that's in our grade book already?
It is not. That is my error. I am going to go fix it right now. I'm going to update your syllabus to put in that new rubric that is under week 4. And then I will fix your grade book as well to make it be a complete incomplete for a practice test A and B and change the 100 points for the proctored.
Okay.
So I do apologize. I will 100% take accountability for that error. So any other questions on it?
Nope.
Okay. You guys all can email me if you have questions.
What was your name again?
That's Dr. Bowling.
Dr. Bowling. Okay, awesome. Sorry. Now I have a face to a name.
Oh boy.
And if anybody is still confused, I can literally send the email that I received from my ADON because she basically said the same thing that I said from the beginning.
I'm not gonna say anything.
You're still recording.
Yes.
What time are you leaving today?
4:30.
Can we talk before you leave?
Yes, ma'am.
Thank you.
You're welcome. Okay. Corey, you have an appointment at 3. Does that mean you have to leave to go to your appointment? I can't hear you. You're on mute.
I have to leave no later than 2:50. His doctor's appointment's about 10 minutes away.
Okay. All right. Let's hop off here so I can meet with Corey, please.
All right. Thanks
Bye.
again.
Yep.
Bye.